Scott County, providing safe, healthy, and livable communities.
With that, we are going to move to number 10, innovation, exploring and adopting new technologies and processes with the goal of improving service and reducing the long-term cost of service delivery. Leslie.
Mr. Chairman, thank you. Today our topic for Scott Delivers is the mental health crisis, and it's one of your board strategies is mental health. And they've actually been one of the groups that in different ways have been here over the course of the last couple of years talking about it and have been developing data over that time frame. So with that, we'll go around and introduce ourselves here, and then they get a few minutes to kind of talk about the background of the program, and then the panel will have some questions for them. We will then open it up to the audience for questions and then turn it back to the board. So with that, I'm Leslie Vermillion, the Deputy County Administrator.
I'm Danny Lenz, the Chief Financial Officer.
Brad Davis, Planning Manager.
Jen Schwartz, Health and Human Services Admin Director.
I'm Julie Blue, CEO of Guild Incorporated.
I'm Karen Jensen, the Supervisor of Canvas Health, Scott County Mobile Mental Health Crisis Team.
I'm Lori Reller. I supervise the Adult Mental Health Unit here at Scott County.
I'm Jody Kieser-Kisting, and I have the pleasure of handling commitment law for the County Attorney's Office.
Luke Hennon, the Scott County Attorney.
Perry Raditz.
Here 4 years.
Are we just making stuff up, or? Okay. I'm Terry Raditz, and I'm the Director of Scott County Mental Health Center.
Good morning. I'm Danielle Fox, the Adult Social Services Manager. I have the privilege of introducing this group today. Thank you for having us. As Leslie said, a lot of this work had started in 2014 with the board strategy around ensuring that mental illness not be criminalized in our community. I think we've had a number of topic discussions with this board and exciting things that have happened around treatment court and reentry and crossover youth. That is not our topic of discussion for today, but worth mentioning because it's part of our mental health continuum. Our focus today is really on mental health crisis. So that sort of pivotal point in someone's life in our community where they're experiencing a mental health crisis and need support in that moment. So we have a number of our experts here today. Within the last few months even, we've had a lot of exciting momentum of moving some of these things forward for Scott County. We had a new mobile mental health crisis team with Canvas Health launch April 2nd. We received word that we will receive $1.9 million in bonding funding from the state to develop an IRTS facility in our community. So this really just makes it a very timely discussion to have with our community and with our board, and we appreciate being here today. I'll let each one of these fine folks introduce themselves and a little bit about their program.
Okay. Again, I'm Terry Raditz. I'm the Clinical Director of Scott County Mental Health Center. As you're well aware, we have an outpatient mental health clinic in Scott County. Last year, we provided services to 4,223 residents of Scott County. Our services include many things that you would typically think of in a mental health center: individual, group, family therapy. We do psychological evaluations. We work a lot with the court system, the county attorney, and the community corrections. We do evaluations. We also do a lot of crisis work for those particular organizations. We work with the jail, doing crisis work with the jail. We do crisis assessments whenever there's an inmate who has a mental health emergency, or if they screen positive for mental health on the screenings when they come into the jail. We've been doing that. We may have been the first jail to do that in the state and have been doing that for 20-some years. We also do a lot of crisis work. Last year, for crisis alone, we provided 401 crisis assessments, and 98% of those were provided within 4 hours of the call. It's one of our goals that we see people as soon as we can. We also do a lot of other crisis work, but those specific 401 assessments were those that were not looking for ongoing services. Many of them did receive ongoing services, but we, as much as possible, we try to schedule someone for a crisis appointment with someone that they can see ongoing, so they don't have to tell their story again, so that it's similar to the emergency room where you would like people to have ongoing mental health care and not use the crisis system all of the time. So as much as possible, we try to get people to see the same crisis worker as they will see ongoing in therapy, so that they don't have a switch in services. We work very closely with case management so that there can be a wraparound of services for those people who qualify for those mental health case management services, both child and adult. And we have a psychiatrist who does the medication piece of that. And we work with DD, developmental disabilities, and other units within the county, because we have crisis in lots of different areas for mental health. And our goal is that folks will receive seamless services, and it will be not a one-shot, but an ongoing. So also we work closely with our new crisis team so that as soon as possible, clients can be transferred to their ongoing and services rather than utilizing a crisis service over and over.
And on the law enforcement side, and more specifically the Sheriff's Office, I appreciate being part of these conversations. I also serve on the local activity council for the mental health board for the county. And what I found is these partnerships with mental health, human services, all these groups together are really what's needed to impact the amount of 911 calls we receive in regards to this topic, the calls for service our deputies and police officers in the cities take, and even more importantly in their jail. A lot of studies show 40–50% of inmates suffer from mental health needs, and obviously increase our workload, and it's not what we're trained to do. No different than the officer going out in the street, as you see in the news. What happens? These people in crisis need the right resources. So we see that also in the courts, the civil commitment transports we have to do. So it increases our workload, in many, many ways, especially in the Sheriff's Office. Every piece we touch feels an increase. And I am a big believer of it's a better spend of our money to do this prevention, do the resources in the community to stem some of these problems and head them off versus me asking for more jail staff or more deputies in the street just to handle these increased in calls. I would rather see the money spent on prevention and getting the right resources in our community. So I think we're on the right track. The mental health help we get in the jail through the mental health center, the Canvas implementation here, and now the IRTS facility. And the next step I'd like to see would be in the future probably even a diversion program on the front end of when some arrests are made. How do we get people to the right services and not into the court system? So we really appreciate the support from the county board on this philosophy of fighting mental health.
I've been handling commitment law for the county attorney's office for a little over 12 years now. And I've noticed over the course of the 12 years just how much more complex the cases are that we're seeing. Not to diminish the work that we did before, but I've noticed that a lot of our cases are requiring testimony with multiple expert witnesses. We have more of those in a year than we used to. The diagnostic picture for some of the folks that we are working with is far more complicated than it used to be. We're seeing individuals that present to us with more than one illness. They may have a underlying autism spectrum diagnosis, and on top of that, we will see that coupled with mental illness. So it's also taking treating professionals longer to clarify the diagnostic picture, which can in turn lengthen the court process as well, or cause those cases to go to hearing that previously we would not have seen. I have the pleasure of partnering with all of the departments at the table because a lot of different legal issues arise in mental health law, not just going to court and litigating issues. We have lots of questions that arise maybe about transport issues or data privacy issues, or just putting our heads together and how can we best address the needs of the individuals that we're serving. And it's a great team to be a part of, and I thank you for the support that you have given all of us in order to be able to do our jobs and to continue to understand that we need resources to be able to do it well.
I'd like to tell you a little bit about what case management is and what we do and our role in this spectrum. Case managers work with the clients that are serious and persistently mental ill. So they're individuals that maybe need more time and resources than just someone that has a mental illness in the community. Some examples of clients that we might serve might have schizophrenia, bipolar disorder, borderline personality disorder, or major depression. Last year, our unit worked with about 260 of these clients, trying to help them stay in the community, work, not be hospitalized, maybe help them if they need crisis services or resources in the community, link them to those programs and get those needs met. Our department also works with the clients that are in the civil commitment process. We do the pre-petition screenings. We screen clients, find out their needs, maybe participate in the court process. And we also will work with those individuals after court to make sure that they're getting those services that they're mandated to receive and that they need. Third element of our department is our community support center. It's called Anchor Center, and right now is located over at the Workforce Center. This is an opportunity for people who have any type of mental illness that live in Scott County. If they're an adult, they can come. We have social recreation opportunities, educational opportunities, and a way for them to be connected without the higher level services that are sometimes needed. Very much like the discussions about the ERTS programs. I know right now when clients need to go to an intensive residential setting, we're looking at going to Mankato, New Ulm, somewhere in the metro. There's no services currently in our county, which makes it very difficult to connect people to resources. Their families don't get to see them. They're living in another community. And having those resources local would be so nice for clients. It would be so easy to connect them to the right services with discharge planning and keep them in our service location. Staff spend a lot of time driving around the state in order to get people in those programs or see them go to their quarterly meetings in those programs. So it would be nice to have those resources here.
Hi, I'm part of the brand new Canvas Health crisis team here. I'm the supervisor of it, and I'm gracious that you have granted us the grant to provide these services here. So we've been very busy from the get-go. We have provided, we've taken on over 250 phone calls already from the community in our first 3 months of service, and we have done close to 70 mobile crisis assessments on both children and adults. And I would say our numbers are fairly equal with kids versus adults that we've been doing assessments on in the community. Our goal is to get out there when these mental health crises are happening right away. Our goal is to try to get there within an hour, within 2 hours for sure. We are out on the scene trying to assess what's happening. And we do this, we provide this service 24/7 in Scott County. During the day, I have several staff, full-time staff on duty that can triage and take the phone calls and go out and on these assessments. And then in the evening, we have an on-call system that is in place to cover those calls. We go anywhere in Scott County to do these types of services. We can go to a person's home, we can go to the school, we can go to, we've done several at the jail, we can go to JAF, we can go wherever we need to go. We've even done one in a parking lot. Because somebody didn't want us to come to their home, so we met them kind of in a parking lot. So we will go anywhere in the county to provide this service. Our main goal is to stabilize the current crisis that's happening, assess it, figure out what's happening, stabilize it, and hopefully keep people out of the hospital. We can't do that for everybody, but if we can, we are able to develop a safety plan right then and there on paper with the client and guardians. If it's a child, we figure out what the plan will be and go over that in detail with the family, provide them a copy, and we have a copy of that plan right away. And then if needed, we'll follow up with some stabilization services, and that will be us continuing to meet with that client for up to 6 weeks. And in that time frame, we are able to connect them to the resources that are needed for them, whether that be a rapid psychiatry appointment at the mental health center, which have been a great service for us, or counseling, therapy, county case management, whatever services they may need, we get them connected with. We're also able to, if they are in need of immediate help, we help with that transition to the hospital. We can do a transport hold. We do not transport clients, but we are able to
do a transport hold if needed, so we don't always have to involve police with our calls, but obviously we know that they're there if we need them, and we do use them frequently and work very closely with law enforcement. But our goal is to try to take time away, to try to have us go out to these kind of calls instead of law enforcement, so that law enforcement doesn't get so tied up on these mental health calls, because they typically take 2 to 3 hours, if not more, depending on what the situation is. So we're very excited to be here, very enthusiastic about the crisis beds and IRTS facility coming. That's a huge need. We often want to put somebody like in a crisis bed or IRTS facility, but they're just not available. So I think having that right in the county is going to be a huge benefit. So we're really excited to partner with them. And I also noticed people don't like to cross the river in Scott County, and I know that because I'm actually born and raised in New Prague, and so Scott County is my home, and I'm so proud that we're providing this service here, and I just really appreciate the county looking at mental health so seriously, because it is a really big need. And I will say there's also substance use often with the calls we go out on. And so we do look at that piece also when we're assessing. We do look at substance abuse and the mental health piece. So, thank you.
I represent Guild Incorporated, and we are the service provider that will be running the IRTS and crisis facility. So IRTS, I think that you pointed out, Intensive Residential Treatment Services. We have our acronyms; they just become words. And we will also be having crisis mental health beds. So the crisis mental health program is up to 10 days, and so we can take individuals experiencing mental health crisis when they are experiencing mental health crisis and come to stay with us up to 10 days. In general, our average stay is about 8 days. That is very much a service that works better when it's local, and that's why I think we're really excited about the commitment for Scott County to provide these services locally. When they're local, your family members, your friends, your support system can be a part of that treatment. So when you have just a short period of time, like 8 days to become stabilized, believe it or not, people do. And we can get people to that stabilized point, do a lot of family work, a lot of support system kind of work, and get people right back into their community. Whereas when they experience having to go to the hospital, the emergency room, that can be a much longer process that can end up at the state hospital. And I think you guys have heard about the state hospital. So really what we're looking at with an IRTS and crisis facility is a way to keep people in their community and help them get the services that they need so that they can transition right out to Terry's program or to Lori's program and get those services much more quickly and to avoid transportation. I think from the staff perspective, the transportation is the hardest part. It equals mileage, it equals time, but from a family perspective, it can mean the difference between a family being able to be involved in that therapy and that connection, because if someone has to work, it just simply isn't an option to take off for half the day and drive to Duluth and spend a few hours with their loved one and come back. And so it does represent, I think, a lot of cost savings when we look at just productivity and labor, as well as keeping people at the lowest level of treatment necessary so that we can get them right back into their lives. So we are very excited to be welcomed into Scott County and to work with Canvas and this year. I think that we have a lot to offer, and we're really excited. As far as need, we do have an IRTS and crisis facility in Dakota County, and in the past year we've seen a significant increase in the demand. And what we have experienced, which is really difficult for my staff, is that we've only been able to help about 30% of the people who come seeking crisis services. And so 70% of the people who are referred to us, we end up turning away because of lack of beds. And so this is absolutely a service that is needed, and it's needed locally, but it's needed statewide. And so we're really excited and just so grateful for the support that Gary, the advocacy that Scott County and Danielle have provided for us to make this happen. So thank you.
All right. Okay, panel, do we have some questions?
You have questions on page 5. When I think of mental health crisis, I'm imagining time is of the essence. So this metric, I guess, reports on how quickly someone gets the service they're requesting when they either call the mental health center or appear at the mental health center. And it must be 4 business hours is some type of state.
No, it's our own goal.
It's your own goal.
So the phone calls are answered immediately, so they get the crisis calls are answered, and then the measurement is we're offering them an appointment. If they want to come in right now, if they appear at the mental health center, we see them, we see walk-ins. The goal is to offer an appointment sometime within the 4-hour period. What makes the time longer is that a lot of them don't want to come in 4 hours. They want to come after work or they want to come later, but we'll see them as soon as they can get here.
Okay. And what I wondered is now with Canvas Health, won't that kind of change the whole dynamic? Because if someone is in crisis and calls the mental health center and needs immediate help, won't you then transfer that to Canvas and then Canvas will go to that person?
No, that's a really good question. So our goal is to provide that crisis service and continuing service and all of the other services that they might need related to mental health seamlessly. Our goal is also to do the ongoing work so Canvas can be available to go out and do the mobile. So they're doing mobile crisis going to the folks. If people can come into the mental health center, then we see them there and they can continue to have ongoing services. So we work in tandem with them. Also, they do after hours and weekends. So.
Dr. Ennis, what's the benefit of within the 4 hours? Is that a specific time period that you've established? I think you said we've set it. What is the benefit to the families and the clients in that time frame versus 2 hours or 1 hour or 6 hours?
Well, our goal is to see them as soon as possible. We initially had a goal of within 8 hours, and we were meeting that 100%.
Yeah.
And so then we moved it up to 4. We could move it up to 2. Often people they want to come in, they want to, choose a time, and they would rather come in 4 hours or at 1 o'clock. And so it's just kind of a random number that we pick, but we wanted to be sure that it was short so that we're measuring that we're getting people in as soon as, we offer them an appointment as soon as they call, but we're measuring what percentage of time or what length of time that typically takes before people take the appointment and come in, before we see them.
Do we know how many of them come in immediately or need it immediately?
I know we offer them that. I don't know what percentage take that. There's a surprising number that will say, can I come tomorrow? Or, can I come after work? So that's why it's a tricky metric. It's like we want to capture that we're providing that service when they need it, but also it could look really distorted because there's many that opt to come in later. Sort of balancing their convenience with being available.
Do you ever see where people say, can I come in tomorrow, and then have decided not to show up by that point? Say, I'm okay now? Not
very often with these appointments. We do have people that we have many people who prefer to wait a day and see the person they're going to be seeing ongoing. They'd rather not tell their story twice. And they'd like to, there's a critical time of forming that relationship, and so we want to honor that as well. So we don't very often have no-shows for these or cancels.
But to your point, a majority of these services are voluntary, but I think these groups are very engaging, and so once we have somebody come in through that door,
once they've made the call, they're
right,
usually...
they've made that connection.
And that's why we want to do it as soon as possible.
On page 9, the pre-petition screenings and the trying not to have a second one within 12 months, can you talk about kind of what a pre-petition screening is and what that process looks like, what we're trying to do there?
The process is if someone petitions to have a individual screened to see they're meeting the criteria that they're a danger to self or others. Usually those requests come from the hospital, from the treating psychiatrist. And so we're looking at providing or kind of mandating treatment because the client is needing that to return to the community. They're not able to discharge without maybe medications. Joe, you may want to talk a little bit more about that piece.
My experience is that a lot of individuals get a request for screening because, as Lori mentioned, individuals believe that that individual is a danger to themselves or others, which would rise to the level of filing a civil commitment case. So usually a screener from Scott County Human Services Adult Mental Health will gather medical records. They'll speak with the hospital personnel, and they'll also speak with the individual that's the subject of the proposed commitment, and then they'll make a determination whether or not they feel that there's enough to go forward. And they work with the county attorney's office oftentimes to talk through that decision-making process, and if in fact it does rise to the level of dangerousness to self or others, then the county attorney's office will file a petition in district court.
What this measure we're looking at is we want to really see if we're able to engage the client and continue to work with them. Oftentimes people may be committed for maybe 6 month period, and then the commitment ends, but later in the year they may need a commitment again, that they weren't able to maybe stay on their medications or go to those services. And so what we're trying to do is not just go through this process, but to see if we can give them the services they need or help engage them enough that they will continue to do the things they need to do to stay healthy.
Okay. That's what I wondered when I looked at this metric. Is the goal really to see the percent drop over time? You're at 15.6%, you dropped to 14.3%. Is that the goal, is to continue to see that percentage drop, or what does that tell you if it goes up or down?
We'd like to see it drop because then we know that maybe we're able to engage them in treatment.
That first time.
The first time. What's really difficult is we work with a lot of individuals that don't know that they're ill. They really think that they're hearing voices. They're really somebody talking to them. They really don't want to accept some of the treatment and some of the help that they have. And so we're working against a difficult issue because someone just doesn't think, oh, I really need to take these meds for the rest of my life. Oftentimes, as soon as the court backs off and there's no longer a commitment in place, they stop medications and eventually will end up back where they were before they started that process.
And this is a fairly new measure. I mean, I think we've got a limited number of years of data so far, but I think if we see sort of some up or down activity, that could speak to systematically, do we have the services, the continuum of mental health services within the community to meet their needs? If not, we would likely see an increase, but Lori's right, there is just sort of a percentage of that population that will need that continuous commitment or will need that hospitalization. So we don't ever have the goal of making that, I mean, if it were zero, that would be great, but I think that would be unlikely. It would just be showing sort of a system need across the board.
I think it also bears mentioning that the law in Minnesota requires that we follow the least restrictive available alternative that best meets the client's needs. And I think the screeners do a wonderful job of being mindful of that requirement under the law. So there are many opportunities where a screening might be requested, but through the screeners sussing out the facts and talking with the proposed patient, they're able to engage that individual in voluntary services. And that is a continued goal that we would have, and that would account for some decrease in the numbers as well.
Good. Related to more the law enforcement side of this, I know that, Luke, you've made a big effort on getting your officers trained or your deputies trained on crisis intervention. How are we doing from the other police forces in town and having them able to recognize when someone's in crisis, and instead of sending them to the jail or making an arrest, diverting them to services?
Yeah, so we started a few years back. There was an 8-hour, it's more of an awareness class for crisis intervention training for police officers, and that was offered through a grant through the Mid-Waukee and Sioux community. So that got it started and got some interest and got people to start understanding, some buy-in. Since then, at the end of this fall, all of our deputies will be done with it. Currently, all of our patrol deputies have been through it, and we're doing a 40-hour class. So it's a full week of scenario-based training to get them to understand the different levels of mental illness, the different diagnosis, and how to respond to that, how to interact with people appropriately. So we'll have all of our deputies done this fall, and then we've also been working on our jail and 911 dispatchers as well to help them engage people better. The other police departments are all become engaged with this, so there's one of the new styles some of the I know for sure Savage is doing is as part of the training, as part of the, say, 16-week training, they're extending a week and sign them up for a 1-week class when they're new. So we're starting to see more buy-in and more interactions with that, which is very helpful.
And then as we're seeing people brought into the jail, are we seeing people who probably could have been diverted to another treatment or another option if the officer had had training? And do we do any sort of tracking of, hey, you know, we have these 10 individuals who were brought in the last couple of weeks. They probably didn't need to be arrested and sent to jail. They probably could have been provided other services.
And I think the best way to explain that scenario, it's not so much the officer goes, I know what to do with you, I'm going to charge you with something, but it's usually that there was no resources up front, and it spirals where now the person gets arrested. So, for instance, the call we may receive is a parent saying, hey, my adult child isn't taking their medications anymore, and they're starting to struggle. And we get called to that, and without crisis response availability, then we don't have a lot to offer. So we go and try to navigate that a little bit. Well, all of a sudden 2 weeks later, we're there, and we've been there 6 times now for different calls. And now this time somebody got assaulted, and then we're forced through, say, a domestic violence law to make an arrest. So what we see is a lot of, it ends up forcing our hand because there wasn't an early intervention that took place.
And actually, sorry, I'm taking up the time, but when we go on a response with Canvas Health or some other emergency crisis intervention service, do we provide any resources to the family members to say, this is what you should be calling instead? You know, if you feel like you're in danger, yes, still call the police, but this is the path you should be going down. This is maybe how to de-escalate, like some opportunities for de-escalation training for them, and also some how to cope with this sort of repeat behavior.
Yeah, so as the deputies and officers in the community, they've been all, I think you've gone to every police department probably, right? Or almost all of them. So there's been a lot of talk in the last couple months about it, so it's just getting that adoption now of them to think of it. And we still see a couple calls here and there and go, oh, hey, did you remember to also offer that? You know, but we're trying to get that out and offer it and make it more public. And the officers are having a positive response too, knowing that they have a resource where in the past they didn't feel like they had a lot to really provide to the family to say, hey, next time or early on, here's another resource for you. So,
And part of that is that resource is so new. I mean, we just launched April 2nd, so Canvas has done a very nice job of sort of getting out there into the community to talk about it and to make people aware. But there are, I think, some additional targeted marketing techniques that we could utilize, like working with our 911 dispatch teams to make sure that people have those resources so that they don't get to sort of that point of needing to contact law enforcement.
And speaking to your question about are we monitoring, so when we go, the mental health center goes out and goes to the jail to assess anybody who comes in with mental health symptoms, we are seeing an increase in folks with psychosis in the jail, and the issue I think will be partly addressed with the IRTs, because currently there are people in the jail with psychotic symptoms who would be better served in a mental health facility. There's no place local to take them, and often the hospitals won't take them after they're arrested, so it's hard to go from the jail to the hospital, as you know. They often won't admit them because of the legal pieces, so it's kind of a vicious circle.
Mm-hmm. And just to kind of, sorry, back on that, if the mobile team does go out and do an assessment on somebody, we actually teach coping skills right on scene and do them with the client and develop a coping toolkit for them with the client so that they have some coping skills that they can utilize. So we do definitely do that, and we do a lot of psychoeducation on when we're out on the mobiles with both the client and the family on different things that they could do to maybe handle things so that they don't escalate again. And then, like I said, connecting them to the right services.
and those follow-up visits that they're doing is one of the biggest impacts that law enforcement will see, because historically you would see placing somebody on a hold because of their actions or tend to hurt themselves, and then you'd be like, oh, I'm coming back 8 hours later or 2 days later because the problem wasn't fixed. And now knowing that there's resources given to that family for the next weeks afterwards will be a big reduction in the amount of calls we see.
We're also seeing proactive contacts from law enforcement with the county attorney's office, with human services as well. If they've gone out on a call where they've encountered someone that has a mental health concern, they'll give us a copy of their report. They'll let us know so that we can reach out to them or monitor the situation if there's something that we can do.
And so the measure that we'd be looking at to be impacted by this is going to be the page 11 one, right? The number of suicide and mental health calls to emergency dispatch. We really want to divert that.
Terry, you mentioned the increase. So on page 6, that's a big jump between 15 and 16. It's like several thousand almost. What's behind that story?
Well, multiple things. We have a new electronic medical records, which is system, which is counting things more accurately. We used to, we'd have, for instance, all of the jail inmates that we went to see and assess what fell under one category. Now they're counted separately. We also have more providers, and we have more people seeking services. So it's kind of a three-pronged increase.
So
I thought it had, I'm sorry to interrupt. I thought it had maybe something to do with the Connect program, and so we were counting more students.
Yeah, we
in
have had
2015.
most of our, well, all of our increase in providers is within the Connect program, which we had previous to this, but we've, as you know, we've grown, we've gotten more contracts with more schools. So we definitely are seeing more people.
And then, are these the same people year after year generally, or are these new clients every year that you're showing on this?
Typically new clients. Certainly some students you'll see, for more than 1 year, but we have lots of new referrals.
These are all new.
And we're serving new and more schools, so, yeah.
And have you ever broken down how many of these clients were in part of the jail population over these years, or can estimate?
We did statistics on that for the board work group. I don't have them with me, but we looked at the several things. We did case study analysis and found that many of the individuals who had multiple arrests and had not positive outcomes had been in the social service system. Hence, we started some of those programs, the Crossover Youth. And we also looked at the percentage of the inmates who had mental health issues.
Mm-hmm.
So I wanted to tie that question back to the actual community indicator that we've been looking at, which was the proportion of population per one mental health professional. And it appears to be going down, and the board's strategy is really access to. And so we're public, but we have a couple private providers here. How do we interact more, and is there still a need in the community-wide, even from the private sector, in your opinion, as we look at that community indicator?
Well, I think, I don't have statistics on this, but my experience with this is that we have a strong need for the IRTs, for the crisis beds, for the short-term stay. We had a need for increased chemical dependency treatment and services, which I think also is happening. In terms of outpatient services, we're doing pretty well with that. I think Scott County may be one of the only places where you can, if you have a mental health need, you can get that need met either through your insurance or through your, for sliding fee based on need at the mental health center. We haven't seen a strong need for more outpatient clinic services. Is that kind of does that answer your question?
Yeah, I mean, as we were watching it, it just seemed, like the county population per professionals to the state, where, we're like double the rest of the state. But it's been coming down, which seems to me to be a good indication. It appears to be a combination of public and private, and so just I was looking for your thoughts on that.
There's more clinics here. I think when I'm interviewing people, the folks in private practice they struggle. So just your outpatient therapy service is, there's a lot of those. It's the folks that don't have resources, don't have insurance, that have a harder time getting their needs met. So I think we're really fortunate that the board supports a mental health center where they can access a sliding fee.
It does, I think, also speak to just our general labor shortage of mental health professional staff. I mean, we have challenges filling open positions sometimes, especially for certain types of programs. So I think something that we have to be mindful of when we're planning for future needs.
On page 8, the locus scores, so that seems to me to indicate that despite working with them, we are seeing an increased complexity or increased needs. And so can you kind of talk about, I guess, is that what you're seeing, and what does this measure show to you? Does it show that needs are more complex, or
It does kind of show that needs are more complex, that what we're trying to do is measure over time if their needs are decreasing. Again, there's a portion of our clients that probably always need some type of service, but would they need more intensive service? And we're just really being challenged with some of the clients that we're getting in that are very complex, that have multiple diagnoses, is just a lot to work with. They're making progress, but they have so many things that they have to accomplish.
The other thing I wanted to touch on page 11, the number of calls we're getting through dispatch, it seems to be pretty flat. And so we're talking about having more and more mental health needs. And I'm wondering, is that what your officers are experiencing, or what you feel about that
It's
message?
challenging to also pull out accurate data
Okay.
because each call we go to can only get classified as one type of incident. So a domestic assault may really be a big mental health issue, but we're making an arrest for domestic assault. It gets that criminal incident attached to it, no different than some of the other missing person or other calls like that. They're going to end up with the bigger of the classification, and then these are more reserved for specifically it comes in and says I'm suicidal or I'm having a mental health issue, and then it gets attached to that. But what we see is it ties into, like I said, a lot of these arrests and other calls really have a mental health component, but there's no easy way to capture that statistically.
Page 10, the number of IRTs and crisis bed days. I'm trying to just understand what this data is. These are the number of days that a Scott County resident needed a crisis bed or an IRTS bed, regardless of where that facility was. Give me a little bit more on this.
Correct. So these would be the individuals that Scott County is financially responsible for. So they could be currently living in the county, or they could be in a location somewhere else across the state, which is more than likely the case because we're right now traveling long distances. So the bed days, as we talked about sort of the timelines, it could be they're in the residence for 3 days or they're there for 10 days. That would be reflected here.
And so an IRTS stay can be up to 90 days.
90 days.
Whereas the crisis is just 10. So that accounts for the
Which can also speak to sort of those increased intensified needs that the residential programs are trying to support that individual with, because you could have, if the bed days are growing, we also look at the number of individuals who are going into the system, but how long are they in that system and what's the reason for that? So is it because they had higher needs and so it took longer for them to sort of stabilize? Is it because there wasn't a less restrictive program to send them to? And we've just sort of been looking into that a little bit further and learning from that.
I think as we bring more IRTS and crisis resources to the area, I think what we'll find is that, so the police calls that are currently going to the jail, so you may see somewhat of an increase because we'll have the facility here, but what it's representing is that it's so for example, St. Francis is just excited about this because they get a lot of people in their emergency department. They just really don't have any place to put them. And so they're waiting for other beds across the state or at other hospitals. And so we're expecting that a lot of the crisis referrals that we'll get are diversion from the correction system, also diversion from ED, and then also the population that you're currently having at IRTS. Because we bill and it goes to the state, this doesn't represent necessarily a cost, but more of a need to the county. And so what I would say is that potentially because of the barriers to getting into an IRTS and crisis facility are now driving as far as, as someone might have to, they may be just kind of making do with local resources that aren't quite meeting their needs.
So when the IRTS facility opens in Savage, we'll likely see maybe an increase in IRTS bed days and maybe a decrease in crisis bed days, or is that not really tied?
Well, I mean, as Julie talked about in the beginning, there's been a shortage of beds across the state. So there's a number of people who are just sort of sitting there without services, whether they're in the community and they're not getting their needs met, or they're at a more intensive, more costly service and they can't step down to a lower level of service because it's just not available. So we will potentially see an increase of both of those bed days, but I think that's more of a picture of people being served in an appropriate setting as opposed to sort of a negative impact.
So Danielle, then besides being served in the right setting though, it sounds like there could be some cost benefits, right? Because being in the right type of facility reduces the higher cost, if I'm following what you're saying.
Correct.
And we must also spend a considerable amount of staff time and travel, if I heard Lori earlier. So you're expecting to see some reductions potentially then?
I think
plus
some
benefits?
potential reductions. I think there will always be that need for people on occasion to be served in those higher intense facilities. But for example, in 2016, we spent over $850,000 on Anoka Regional Treatment Center costs for people who were deemed to not meet criteria. So having one IRTS facility in Scott County is going to be helpful, but there, I think, are needs across the state that will need to be met in order to make sure those people are served in appropriate settings. But there is definitely a cost benefit for people to be served in less restrictive settings.
Plus the benefit of their family is closer to them, and from a recovery standpoint.
Yes.
Will the goal with the IRTS facility be to limit it to Scott County residents, or will we balance with other counties as we have?
So our concern as the provider is that we can maintain capacity and so that we're providing the need. And so that will mean that people will be coming from other places to the facility. However, it is clinically indicated that if someone is closer to home, they're going to have a better clinical outcome than if they're farther away from home. So for example, our facility in Dakota County, we prioritize individuals who live nearby. So that approximation, the geographic location matters as far as the clinical outcome. And so when we're looking at giving priority to, as I said, we turn away 70% of people. And I don't think adding this one facility is going to make a huge dent in that. We will probably be still turning away people. But the advantage of having it in your community is that those individuals be prioritized. So if we're looking at a referral from, St. Cloud and one from Savage, then clearly you're going to have one from Savage. So. I think we look at a greater, so we talk a lot about health reform and health costs from a federal level and Medicaid funding, and there's a cost reduction seen by adding these facilities in that regard as well. So someone being in a psychiatric hospitalization costs about $3,000 per day. State hospital is about $1,300 per day. Staying at our facility is about $360 per day, depending on it. So from this cost system and cost to the community, there's a really strong argument. We believe as the provider that our program manager did her doctoral thesis on outcomes based upon that intensity of service, and what we've seen is the same person in a psychiatric hospitalization versus an IRTS facility. The outcomes are about the same, if not better, in the IRTS facility for such a lower cost, so it just really makes sense all around.
And also a prevention measure as far as trying to keep people out of our jails, trying to limit time that the sheriff's office is spending sort of going out on calls, because if we can get their needs met and they're doing well in the community, there is an overall benefit to that.
And part of the treatment is integration into the community, so whereas if you're hospitalized or in jail, you are there 24/7 and you're not living your life, you're not participating in your life. If someone's in an IRTS facility, say in Savage, and they stabilize fairly quickly as far as those acute symptoms, they could go to work while they're at the IRTS facility. So if that's the other local, you can see, local benefit. And so you're not necessarily just removing people out of their life and then just plopping them back in when they're better. Because generally when you're ready to be discharged from a hospital, there's still a lot of need to transition back home. And so what this level of treatment provides, especially when it's provided locally, is that transition and that flexibility.
That's when I was going to ask you, Luke, about your diversion statement you made early on and where you hope you're going. Because at Justice Steering, you'll hear the discussions about we jail them and then they lose their job and then they lose their house and they lose their apartment, and we have this whole family now that's impacted. So what you just said makes huge sense to a solution there, but what are some of your thoughts on that when you mention that?
There's a model down in Blue Earth County right now called the Yellow Line Project, and they have some crisis people in the jail, embedded in the jail, so when a new arrest comes through, if it meets certain criteria of nonviolent crimes, things like that, they can assess that person there, and the officer can decide, you know what, I'm not going to charge this person with disorderly conduct because they were, walking on the street, yelling at people and acting out. This is really a mental health issue, and then the diversion happens when they can get them transferred to the IRTS facility or to the resources, to caseworkers, and not let them get involved in the criminal justice system for that activity versus just having them go through that and then get maybe a warrant 2 months later because they missed court, and they're just kind of in this cycle where they're losing their job because of all that. So there's some ideas. Yeah.
Nationally, we're finding diversion programs to be really very successful. And I recently just visited Memphis, has a facility in which the police directly bring individuals that meet their need to their facility, and they're able to transition them very quickly to mental health professionals who can then, there's just so many advantages to moving from the law enforcement because there's so much people experience trauma. In law enforcement in general, when you're in prison, people aren't thinking about your well-being, they're thinking about punishing you. That's in the public safety. Whereas when you can do a really quick transition from just anyone who's wearing a uniform and is law enforcement to a mental health provider, there's so much benefit to the individual, and they stabilize much more quickly, and it's at the right place at the right time. So my ears perked up when you said diversion, because I think it's a really exciting opportunity, and in a smallish community, I think there's a lot of good potential to pilot.
And in the jail, the struggle we have too is the Department of Corrections says, okay, your jail is this big, you have this many different housing areas, here's how much staff you need, which sounds good on paper, but when a high percentage of your inmates suffer from mental health issues, that work that each officer is trying to get done each shift to keep the building running, when they have to shift gears and spend maybe 2 hours just dealing one-on-one with one inmate, or 2 officers spending one-on-one with an inmate who's really struggling with psychosis, to get them to engage or get up, take a shower, or do anything, really takes a hit on their staff as well. And once again, they're not the professionals that are trained for that, so it's just not a good system to have.
And Sheriff Hennon spoke to this earlier. We have to have some other resource to provide these people. So we've gotten some of those key pieces, I think, in place. So I think that is one of the next steps of, do we look at, is that something that would make sense for Scott County?
Yeah, you've helped me definitely with the puzzle, the process person I am here. So I was sitting here thinking about calls, and if you can handle it, we handle it right away. If it's evening, weekend, or a mobile crisis, you're out there, right? We try to get you seeing people continuously so they have support. If they have to go to the hospital, they've got that support. Long-term, you're working with them. If they go back into a crisis, you have these resources, right? Are we on the right track here as I'm thinking through it?
And so we're sub-hospital, so that's the only, I'd say, so there are times when people meet criteria, they're an acute danger to self or others and need to be hospitalized. But the IRTS facility and the crisis mental health is just sort of one level below that. Yeah. We have definitely seen, especially as we get to know people who've got repeat hospitalizations, that they can say, I really think I can do this in crisis, even though they're meeting that hospital level, but the hospital is still a piece of the puzzle that we're not necessarily talking about.
Well, and they're in and out of the hospital so fast.
To the right.
Yes, then there's
the right service, the lowest level, and Luke's staff are much more in tune and trained to trying to help us get to the right services. So these two missing links here are big pieces from the board strategies and objectives coming to the table to help support. Questions from the audience? I'm hearing this kind of quiet here now.
I'll ask one. Is there a particular season when you see demand increases, like summer versus winter? Because we all get anxious in winter, so.
What? It's nice.
I think that sort of ebbs and flows. I think, seasonal changes can sometimes be challenging for folks. We sometimes are extremely busy on the holidays and sometimes not at all. So it just sort of depends to answer that. But
in the mental health center, we used to sort of depend on a little bit of a lull in the summer and to get caught up on things. We don't see that anymore. It's continuous year-round. We also see increase when there's societal events, trauma events, things that are upsetting to people. We see a big increase in crisis calls and calls for services at the mental health center.
Or when there's a drop in those resources. So is there a large apartment complex that has closed down, and so now there are affordable housing issues for a large portion of people? Just sort of any of those things can cause an uptick in service needs.
I was just going to mention, I thought it might be important to mention a phone number since we broadcast this, if there's a mental health crisis number we should share.
Sure, you want mine?
Well, I'm just wondering if someone or...
You want the crisis line though? Is that what you're asking?
Well, I guess I'm asking if someone in our community has
Yep.
mental health issues or one of their family members, where do we direct them?
So 952-818-3702. That's the 24/7 crisis phone number for our services. The mental health center has it.
Yeah, for all the other services, they can call 952-445-7751, and it'll direct to whichever department.
That contact information is on the Scott County website as well. And Canvas is actually going to come back and do a presentation specific to mobile crisis services in an August board meeting. So
I'm going to ask each of you, if we were sitting here a year from now, which I'm assuming we probably will be or sometime, what would you hope to see different a year from now, just in a couple seconds, sir?
Well, I am, biased towards Guild. Obviously, I hope that Guild is more involved in the Scott County community, and that we're seeing, I hope that we're seeing that we have enough people to keep our facility running from Scott County who are appropriate referrals and are thriving in our services.
Karen?
I think for us, it would be to see those initial phone calls come to us versus law enforcement when possible, but especially those mental health phone calls, because we really can do a lot. And if we need law enforcement, we know that they're right there. I think we're really fortunate to have good connections between law enforcement and mental health in Scott County. A lot of counties don't have that. So that's really an awesome thing. So I'm just hoping that our program grows too, and that we're able to serve people well.
I think for case management, we're looking forward to the intensive residential service being up and running next summer, because I think that's one of our biggest missing links at this time.
I'd like to see our number of days in crisis beds higher than our number of days in IRTS facilities, because that would mean that our citizens are transitioning back to living in the community and resuming their lives quicker.
I'd agree on the Canvas Health topic of, as this program matures and we get our feet on the ground, to see that transfer of more calls, more interaction between law enforcement and Canvas, and some reduction in the activity that law enforcement is part of.
And I'd like to see us just continue to make this seamless service so that our transitions among all of these services are really seamless and not even apparent to the client, so that they just know that, whenever they call and with a mental health issue, that those needs are being met, and the follow-up as well.
all of those things, yes. I hope we see construction actively happening on an IRTS facility. I hope that Karen's team is known across the community as far as a service, and they can continue to respond timely so that our volumes aren't getting too high that we can't manage. I hope that we will be able to have some conversations about a potential diversion program to see if that's something that might work for us. And as Terry pointed out, I hope we continue to have a close partnership. This group has worked really well together, and I think that's what has really made us effective in moving forward mental health work. So that would be great.
I remember the first time Terry came, and it was pretty much Terry in the mental health center, 4 years ago or whatever it was. Maybe it's even 5 years ago now. And to watch the partnership and the discussion it's pretty impressive to see how seamless it is and how you work together. So turn it back to you.
Okay, Commissioner Ulrich.
Yeah, I have a bunch of questions about the IRTS, and I don't expect them to be answered here. I just want you to think about them. I understand that the details and contracts and some of that is still in work, so that's the reason I'm asking these questions. Based on my math, and my math is not always that great, about a third of the bed days, up to about a third of the bed days would be used in the current scenario by Scott County residents. and then 2/3 would likely be used by outside of Scott County. I did, multiplied the 60 by 365, and that's how I came up, with these numbers. And so I want to make sure, one, that those beds are really available when they're needed in Scott County. And I understand you're working on provisions that will help with that, and I'm just wondering if the, well, what I understand is that there'll always be a bed for a Scott County resident, and that when that bed is filled, the next bed that's available would be for a Scott County. So there'll kind of always be a Scott County bed. I'm wondering if that would meet the capacity of 1/3. I have the opposite concern. I think in the first month you'll be full, and you'll never be anything but full, based on what you're saying to me. So anyhow, I'm concerned that there'll always be beds for Scott County residents. That's the one thing. Then the other thing is, if the 2/3 are coming from elsewhere, and you must, if you can say 70% turn down rate, you must have some data on where the requests and turn downs are coming from. I'm hoping we can have that data to talk to those, whether it's Dakota County or Carver County or St. Francis or wherever it is, say, hey, X amount of bed space has been requested over the last year by you, and we're going to have an ongoing debt service of $200,000 a year. Would you be willing to share in that debt service of this facility based on your turn downs of your request for bed space? So again, space for Scott County, but sharing the cost for those that are going to end up using it, because it looks like 2/3 is going to come from outside Scott County. And again, I don't expect answers today. I just wanted to lay that out in your deliberations. The other question I had was for Luke. There's no judgment in this. And I don't know intimate details. I just know what I read in the newspaper. There was a health call in Carver County, mental illness. A parent called, child was suicidal, dangerous in every way, and it ended up with a bad result where that child was shot and killed. And again, I don't know any details. I'm not making any judgment on what happened because I don't know any of the details, and I wouldn't even try and go that direction at all. But my question is this: at one time, we were paying for additional training for law enforcement dealing with mental illness type calls. And I'm wondering if we could get an update on that, and are we spending enough? Not only, I'm not just thinking the sheriff's department, I'm thinking of all the local law enforcement. I know they were spending a lot. There was quite an initiative in that, and I just would like an update on that. And if we're not spending enough, I think we better make sure that we are. But
yeah, so that's the crisis intervention training. And like I said, we've been doing earlier, I mentioned we're doing a 40-hour class, which is the comprehensive one to certify people. And that's where we expanded it in the sheriff's office to our dispatchers, our corrections officers, and then most importantly, obviously the deputies. So we're meeting that goal. I've increased next year in the budget to get more of our dispatch and corrections officers through it to keep them going through it, because it's a spendy class for a full week. And then each city is doing their own funding and their own process of their ability, but it appears to be catching on quite a bit, and in most agencies are doing it. The other advantage of last year is I had got a donation from a community member that provided, I think it was about $14,000, that really helped us boost it, so we sent 22 additional people last year through that full week. And then because of our regional training facility, it gave the capacity in the community as well, because normally to sign up for that class, you may have to send an officer to White Bear Lake or to Anoka or somewhere, a significant drive. We were able to host, I think, 3 or 4 in Scott County last year. And this year, I know Carver County has been doing a big push to send their officers, so they're using the RTF, and I think they have 4 courses locally in Jordan as well, which makes it a lot easier for instance, a small police department to send somebody locally to a one-week class versus all the travel time and expense that incurs. So that unintended consequence was there was more offerings locally, and I think it really helped get more officers trained in that.
And that's great, and I'm really thankful for that effort. If through scale in your meeting with the chiefs and so forth, if you see gaps and there's funding barriers, it would be nice for us electeds to know that. Thank you.
Thank you. Any other questions or comments from the board? Commissioner Brecky.
Thanks. Karen, I know it's been a short time, but so far, can you gauge the % of calls, mobile crisis, when you go out, that you're bringing law enforcement with you, that you're doing it together versus not? Is it 50-50? Is it?
Oh, gosh. Actually, I would say a majority of our calls, we don't have law enforcement there
Great.
so far. Yeah. But I would also say we get a lot of referrals from law enforcement to go out, like maybe after they went out on a call with somebody, we'll follow up with a phone call and then go out there and see them.
Okay.
So we haven't done, we've done a few together, but not a lot. But I think we're honestly just hitting the tip of the iceberg because I think there's a lot more need out there than what we're doing yet because the change in the phone number and things. I'm working behind the scenes because there are people who definitely don't know about the change of phone number. And so we're working on that piece too. That's been a barrier a lot. Some of our phone calls have been going to Hennepin County and the old Carver Scott team. And we would hope that they would send those calls over to us, but I don't know if that's always happening. So I think just getting our number out there is huge. Like the National Suicide Line, I don't know if you've heard, but we used to have our own local resource at Canvas Health that took all those phone calls, and that went away at the end of last month. So now all of our people in Minnesota who call the National Suicide Line are being routed to a different state, and they don't necessarily know all the resources or getting the people to the right resource within their own community. So we're trying to work with some of those folks to make sure that we're getting all the calls coming to us from people in our county. But as far as law enforcement with us together, we haven't done a lot yet, but definitely have worked very closely with them on cases.
Right. Yeah, no, I think that'll be really interesting for us to find out. Yeah, and that's something I didn't think about. How many referrals are you getting from law enforcement?
Yes.
How much are joint visits? That type of thing. And yeah, just the demand you've had in such a short time, I know it's going to be busy. And then, Luke, do you have any data, like, I suppose it's too early yet with the mobile crisis, but have you been thinking about data to collect to show cost savings from the work we're doing in this area?
I think we'll have to figure out a way to gather some of the data, but like I said, our records management system is geared towards criminal incidences and things, so it's figuring out how do we show what that really means, the reduction of calls versus just a feeling that we're taking less calls. But there will always be a struggle too with a lot of the calls that come 911 are emergency calls, so that deputies and officers still are going to have to go, and the crisis team won't be able to meet us there until somewhat later. So we still will place people on holds, secure weapons, do things like that. But we're hoping to catch, just from looking at, I know Ramsey and Dakota do the diversion where they can transfer the call straight to crisis and never dispatch an officer, but they found it's a small percentage though still that doesn't, that for safety reasons aren't a law enforcement call up front. But so it's a lot more of just as we work together and learn what everybody's strengths are, the officers will learn when those calls can be diverted easier and things.
Just one more. Dr. Raditz, so when calls come in, and I assume staff and the person calling deem it crisis or non-crisis, right? Is there some kind of screening for that, or?
Well, we just ask them how soon they need to be seen. I mean, if they're calling and it's they're suicidal.
Right.
At that moment, obviously, we never get off the line and we just move forward with that. But we ask them, and if we feel like maybe they should come in sooner, we'll encourage that. But we ask them when they feel they need to be seen, and they want to be seen.
And do you have an idea what the kind of average time to be seen is for someone who calls in where it's not a crisis?
I don't.
Days or weeks?
It changes. It can, we have urgent crisis and we have urgent. So people who need to be seen quickly but not within hours, we set those up for within a day or a week. And then there are people who, it really depends on, if they say I can only come in on Wednesday nights at 8 o'clock, then they're waiting longer. Or if they say I only want to see this provider, and that provider is already full, they may wait longer. If it seems like, in the assessment that there's a crisis, we will encourage them to come in as soon as possible. So the wait, it varies.
I suppose. Thank you.
And one of the connections between Canvas Health and the Mental Health Center is there's an availability for rapid access psychiatry appointments. So sometimes there might be a long waiting period for someone to access a psychiatrist, but if they are in the community and they're in crisis, they have an ability to get those folks in much quicker.
Thank you.
Okay. Any other questions or comments? Okay, seeing none. Thank you. Very nice.